All right, are we ready to get started, I think? Great. So welcome everyone. Thank you so much for taking the time to join us for this webinar on mitigating risk of COVID-19 and overdose among people who use drugs, a BC-wide evaluation. Our presenters today are Dr. Bohdan Nosyk. Sorry, I probably should have checked exactly how to pronounce your last name, Bohdan. I apologize. And Dr. Karen Urbanoski. And I just want to acknowledge that I'm Amanda. I'm here at the Canadian Institute for Substance Use Research at the University of Victoria. And where I am right now on campus is the traditional territory of the Lekwungen peoples and the now known as the Songhees, Esquimalt, and WSÁNEĆ peoples. So yeah, if folks aren't familiar with the Zoom webinar platform, I'll just give you a quick little overview. You'll see an option for a chat, which is kind of like a general chat function. If you want to talk to your fellow viewers and panelists there, that's great. There's also a Q&A box for questions, and it's a lot easier for us to keep track of the questions that are going to be asked that our presenters will address at the end if you put them in the Q&A box. So if you remember to do that, that would be super helpful. And then we can just kind of collect them there as the presentation goes on, because then if something comes to mind and you want to just put it in there while you're thinking of it, that's sometimes easier than trying to remember something at the very end. So without further ado, I'm going to disappear here and leave it off to Karen and Bohdan.
Thank you, Amanda. Okay, so lovely introduction. We're really pleased to be here today to kick off this being our inaugural webinar for what we're calling the CoLab. And I'll talk about that in a moment. As Amanda has already acknowledged the traditional territories on which the University of Victoria stands. I'll just say it's a pleasure to be here, and I do reflect in these moments when I am getting ready to present that this is unceded territory, and we're very aware that the criminalization and racialization and impacts on Indigenous peoples within Canada is uneven and in many ways affects the communities that we work with in a number of different ways. And so I do think about that, and I encourage you to acknowledge the land from which you are joining us today. Bohdan?
Yeah, from SFU, we respectfully and gratefully acknowledge we live and work on the unceded, ancestral, and traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. Thank you.
Thank you. I'm going to get us started with a little bit of an overview of CoLab. So CoLab is the Collaborative Community Laboratory on Substance Use and Harm Reduction. And it's based out of CSIR, the Canadian Institute for Substance Use Research here at the University of Victoria. It's a collaborative network for research and knowledge exchange that aims to promote health and health equity for people who use drugs, which we broadly use to refer to both licit and illicit drugs, including alcohol. The areas of work that we're engaging in at CoLab or under CoLab include equity-oriented monitoring and surveillance, so increasing or expanding capacity for the monitoring of social structural indicators of substance use and related harms and health equities within populations, and as well as innovations in services research, one of which we're going to be speaking about today in relation to the risk mitigation guidance document that's available in BC. And we also have an extensive platform for knowledge exchange through our community of practice. Through the community of practice, we're going to be hosting periodically webinars, as well as roundtable discussions in which different stakeholders from different communities, service provision, people with lived and living experience can come together to talk about different key issues of the day. And this is our inaugural webinar. So we were recently funded to create the infrastructure for CoLab through a grant from the Substance Use and Addictions Program through Health Canada. And we've been very busily getting ourselves set up, and very pleased to finally be in a place to be hosting this webinar. And if you are interested in joining the listserv for CoLab to learn more about it, there is a link there to a website that we have. And also our community of practice coordinator, Brittany Graham, is present, and she's going to do a little spiel on how you can become more involved in CoLab toward the end of our presentation. So today we're going to be talking about overdose and COVID, and so the dual public health emergencies that we are experiencing in BC, as in many different provinces and jurisdictions in Canada. I'm drawing attention here to a recent publication that came out from came out in CMAG a couple of weeks ago that really highlighted how the overdose public health emergency in BC is directly linked to the toxicity of the illicit drug supply, which is relevant to this work in many ways. Now, this is pre-COVID data that this publication is based on. It's from 2015 to 2017, but it really highlights the role that non-prescription opioids and stimulants is playing in what we're seeing now with the very high rates of overdose. And of course, these risks and harms to the population related to drug policy and the available service landscape are really being worsened right now in the time of COVID. This is a quote from the BC Coroner Service, which was from a recent news article that accompanied the release of the statistics for last month's overdose deaths in BC. And it highlights that we know from the data that people who are dying alone. And there are a lot of complications that come with the COVID-19 pandemic in terms of people being isolated, the unintended consequences around the availability of services, harm reduction services, overdose prevention sites, as well as different counseling-based services and treatments and supports. And that people who are people who use drugs are at a heightened risk of a variety of different health complications, including both COVID and overdose at this time. What this has done is it's created a situation in which there's a bit of a policy window for interventions and responses to be shaped. Now, at a federal level in Canada, back in March, we saw a temporary exemption from the Controlled Drugs and Substances Act to help support prescribers, physicians and nurse practitioners who may be working with people who have substance use disorders or people who are experiencing different harms related to their substance use, to try to allow prescribers to prescribe substances to divert people away from the illicit drug market. Now, provinces across Canada have taken this up in different ways, or not taken it up, and which I think is fair to say. In BC, we have this document that you see here, produced by the BC Centre on Substance Use, the interim clinical guidance on risk mitigation during COVID-19. This outlines a variety of different options for prescribers to consider in trying to support the patients that they treat in accessing substances that may be alternatives to the substances that they're purchasing in the illicit market. This guidance document was released in March, the end of March in this past year, and I, like Bohdan and a few others, are part of a provincial consortium that has been of researchers that has been assembled to take a look at what's been happening during this time. Bohdan will talk a little bit more in a moment about the specific project that we have designed to look at the guidance document, but I wanted to highlight I guess the distinction that we've come to really appreciate as we've been going through the beginning phases of this work around the fit with the guidance document, the temporary exemption from Health Canada, and what is more broadly known as a safe supply or a safer supply. This definition that you see here is one that I took from a safe supply concept document that has been published by Caput. And the way that they frame safe supply, which I really like, is that it refers to a legal and regulated supply of drugs that have traditionally only been accessible through the illicit drug market. We recognize that we're not there. And so we thank the many community members, people with lived and living experience, as well as the service providers that we're working with to really challenge us to think through where something like the risk mitigation guidance fits in this broader spectrum of what we might think of as being safe supply initiatives or safe supply interventions. So while we do think of the prescription of pharmaceutical grade substances is part of a broader spectrum of what we can consider to be safe supply. It does not in and of itself constitute a safe supply, which may include other types of interventions such as grassroots efforts, buyers clubs, and the like. And so this is a very different type of intervention. It's one that's medicalized. It does depend on access to physicians and pharmacies. And so I think that's important to keep in mind as we go through our project and what we're looking at. And with that, I will hand it over to you, Bohdan.
Okay, so this is a project that brought three distinct groups together, Amanda Sloan-White and her colleagues at the BC Centre for Disease Control, myself, Nat Hongdalocool, and others at Simon Fraser University and the BC Centre for Excellence in HIV/AIDS, as well as Karen Urbanoski, Bernie Pauley, and their colleagues at CSER. And it was important that we came together this way. I think we all bring our own perspectives and unique aspects of it, unique expertise to the project. And we've put together something that I'm really excited about, which is a mixed methods evaluation of the risk mitigation guidance. So we had three specific aims, and they're all interlinked, and they're all meant to inform one another as we progress with this evaluation. So the high level outcomes the high level aims are first to determine the impact of risk mitigation guidance on COVID-19 infection, the continuity of care for substance use disorders and concurrent health conditions, overdose, and all-cause mortality among people who use substances. So those are our core sort of outcomes that we're looking at in one aspect of our evaluation using health administrative data. But we also want to determine the impact of risk mitigation guidance on the uptake of public health measures to reduce the spread of COVID-19, as well as other behavioral and psychosocial outcomes among people who use substances. And the piece that I'm really excited about, led by Bernie and Karen, because this is a real world implementation happening as we speak, as we conduct our evaluation. So I'm very much interested in the methods of implementation science. I think that sort of perspective really needs to be applied when we evaluate programs here. And so our third aim of identifying barriers and facilitators to implementation based on program uptake from both the perspectives of people who use substances and service providers. I think that's going to give us a lot of context to understand just how this played out from the perspectives of both, again, consumers and suppliers here. So you put those together, and we really believe this is going to give us quite a broad spectrum understanding of not only what were the outcomes of this of these guidelines, but how did the implementation process play out? And how did that implementation process influence those final outcomes? Okay, on to the next slide. So again, our primary investigators were Amanda Swan-White. She is not with us today. She's actually presenting right now she's doing a different presentation for this very project. It's a two-day conference being put on by UBC and SFU. So Amanda's off presenting elsewhere right now. She's our nominated principal applicant. Nat Hongdalakul, I believe Nat is in the audience right now. So was Bernie, and Karen and I are involved. So we're really grateful, and you know, I don't believe that we can do this effectively without the degree of partnership that we have, first and foremost among activist groups across the province. Karen and Bernie have done a wonderful job of connecting us with a wide range of stakeholders. Jane Buxton was very helpful in this regard as well. I believe I saw Jane in the list of people on this webinar, so thank you. We've also engaged the BC Ministry of Health, Ministry of Mental Health and Addiction, who actually came to us and prompted us to evaluate this project, as well as the BCCSU, Perinatal Services, Ministry of Public Safety, and the Solicitor General. So just very wide, a great deal of interest on this project, and a great deal of support that we've had, not only from the organizations that signed on to this application, but also across different health authorities. It's been really encouraging to see so much interest and so much support for this. This is, it's exciting to be a part of something this timely, and it's certainly a hot button issue for a lot of different groups. And so we were lucky enough to have funding from CIHR. This was a rapid cycle. I've actually never been a part of such a rapid grant application and initiation processes. We've really, we put the application together very quickly, and we've hit the ground running here, and we're all very much dialed into this. Next slide. So again, we have 3 different groups, and we're all sort of working on different components of this application. So at CSER and FNHA, CSER and FNHA are really leading our primary data collection, and that's happening in 4 different components. So we have a longitudinal survey of people who have newly received or are seeking risk mitigation guidance prescription, a cross-sectional survey of people who received a risk mitigation prescription. We also have qualitative interviews with people who use drugs, with an additional sample of people of Indigenous ancestry, and interviews with service providers as well. So we're really doing a lot of prospective data collection, and we think that is going to be integral in the other components of the evaluation, which we're executing with the excellent health administrative data that we have across this province. So at the BC CDC, you may have heard, you may know about this, there are really 2 major cohorts that the CDC has linked and put together, as well as our team at the BCCFE. So there is the overdose cohort that is housed at the BC CDC. They have ongoing surveillance data, and they've been able to link to the PHSA COVID cloud. So that's going to give us information on incident COVID-19 infections. That includes community pharmacy dispensing and also vital stats. So that is a near real-time link, data linkage on a more limited set of databases that's going to give us, in very short order, some indication of who the recipients are and what the prescribing patterns have been. Towards the back end, our team at the BCCFE and Simon Fraser University, we're going to evaluate this this project, this program using our suite of linked health administrative databases. And there are 10 different databases. It's coming from our cohort of people with substance use disorder. I'll talk about it a little bit more in the coming slides. I always emphasize this when I mention it. We have our infrastructure for health administrative data is truly second to none. I always kind of hesitate saying that. You never want to be sounding hyperbolic or exaggerating claims, but to my knowledge, there is no better database to help guide public health practice, clinical management of people with substance use disorders. It's truly an incredible resource, and we're grateful to have the opportunity to work with it. We know it's a very big responsibility, and we are doing our absolute best so that we can best serve the province and serve the people that we're looking after. Okay, and within that cohort, we have data going all the way back to 1996. So it's an incredibly rich data source. On to the next slide. Do you want to take over from here, Karen?
Sure.
Okay.
Second to none. I think we can do better. I would like to see our administrative databases for health linked with databases such as, well, particularly from child welfare is what I would like to see. So if you're looking for tips on how to make it even better, got some ideas.
I think that's possible. You know, I think we'll get there. It's gotten better over time, and yeah, you're absolutely right. That would be a really useful piece. Yeah.
And so we've got clearly from the project structure that that Bohdan described, it's a pretty complex group, and they're, you know, with 5 principal investigators. This is going to be a lot of meetings to implement this project. So the way that we've set things up is that we have a core operations team, which is those of us who are involved in project administration, and we get together bi-weekly to just hash out all of the factors that we need to have in place for implementation. And then as Bohdan mentioned, Bernie and I are leading the original data collection, or the primary data collection. So we've separated off to do that piece, and the surveillance and administrative data analysis is Amanda and Bohdan who oversee that piece of it. Now, many of you who are on the call have received invites to be part of these working groups. We've opened up invitations to people with lived and living experience, service providers, health authority representatives, as well as representatives from Ministry of Health and other organizations, to try to make sure that we are creating mechanisms for people to be able to have input into the decision-making that goes on at the project level. We did take a deliberate approach of privileging the voices of people with lived and living experience in this work. And so as we get started, we have had a fair amount of groundwork to be done, brokering those relationships that we've already got on the ground through the work that we are doing, all of us in Vancouver and Victoria, and provincially, as well as connecting with the different people from different stakeholder roles around the province to do this work. There's a very large membership on the research team from co-investigators and collaborators and additional folks who have joined the team since we've gotten started, and they form the larger consortium that we answer to, which we have meetings scheduled on roughly a monthly basis for the next little while we're getting things up and running. And we report back to our consortium on how things are going, what challenges we have, what next steps we're going to be taking. So we really have tried to put in efforts to not just use a community advisory type of approach, but also to involve people with different stakeholder roles in the design and the collection of data, the analysis of data. On that note, I will talk a little bit about the primary data collection, what that looks like. I will say we've already gotten all of our research ethics approvals that we need to have in place to get started on this work, and so data collection on my end is likely going to start in a week to 10 days, we're hoping. So part of the data collection we're doing are surveys of people who have received or who are seeking a prescription currently. So the way that we've kind of set that is that you have to either have received a prescription for illicit opioids, stimulants, or benzodiazepines, or you're currently trying to access a prescription, and you're going to do that soon. And the reason that we've set things up that way is that if people are new to receiving a prescription, or they're currently seeking out a prescription, what we're going to do is follow them over time for 10 weeks and check in with them 5 times. So we've designed a longitudinal survey to check in with people every 2 weeks, just to see how it's going as they're going about trying to receive a prescription or kind of get used to having the prescription available to them. We do recognize that since this document was released in March, there is a fairly sizable cohort of folks who have already accessed a prescription, and they did so in the initial weeks. We don't want to exclude them from the study. We do recognize that they will have some experiences that may be valuable for us to hear about. And so for anyone who received their prescription in the past, longer than 2 weeks ago, we do recruit them to a cross-sectional sample so that we're able to gather information on them at one point in time. We're working closely with our peer partners with the BC Yukon Association of Drug War Survivors, as well as the Compassion, Inclusion and Engagement Initiative, or the PEEP project through BC CDC. To find folks around BC. We're really concentrating on trying to make sure, because Bohdan will talk about the administrative data analysis, but I'll just sort of preface some of that by saying that administrative data can give you a nice, large population-based view of what's happening. And so where these surveys come in complementary is not necessarily by being a representative sample, but targeted sampling of different subgroups to make sure that we're able to capture people who, for instance, are in the north of BC, people who are outside of Victoria or Vancouver, which is not a group that we tend to hear from a lot in BC. So that's very important to us. We want to hear from people who are from First Nations communities. We recognize that people do not have even access to this intervention, to these prescriptions. That's part of what we want to capture. And so we're doing a very targeted enrollment of people who are accessing and who are trying to access but not able to a prescription. The survey, just briefly, and feel free to contact me at this email address if you would like to talk about this aspect of the data collection. It's going to capture, in addition to information on people's sociodemographic characteristics, details on the prescription that they received, what that looked like, how they got it, how long it was for. We do anticipate that, people will receive a prescription, they may not fill it, they may or may not take the medications that they've had prescribed. They may be on it for a while and then shift. And so there's some of that variability we'd like to capture. We'll ask them about their substance use and related harms, health and wellness, what their experience has been around COVID, whether they've found that having the prescription allows them to be able to engage in physical distancing, for instance. But just overall, what their experience has been during COVID. This is clearly a very important time right now, and we do want to get some information from people on what their experience of the pandemic has been like. And finally, police encounters. From the people that we recruit into the survey, we will be recruiting a subset to complete more in-depth qualitative interviews. The qualitative interviews are based on the Consolidated Framework for Implementation Research, which is a commonly used implementation science framework. And so it has helped us to structure an interview guide, both for people who have received or who are seeking a prescription, as well as service providers. Again, both service providers who are providing prescriptions and those who have opted out, those who are not. Because we want to get a variety of, want to get some in-depth insights into the characteristics of the recipients, the process of implementation, what that's looked like, what prescribers and service users have had access to, what they haven't had access to that might have been helpful. What are the characteristics of the intervention in terms of their accessibility, eligibility criteria, so the way that providers are interpreting who is eligible to be participating in this. As well as the inner and outer context in which this intervention is functioning. And so what this is going to do is it's going to help us to be able to interpret some of what we're going to see in the administrative data around pockets of the province where this intervention has not happened, it has not occurred, or pockets of the population that have not had access, whether it's women with child welfare involvement or people who live on First Nations communities. And we are working with the First Nations Health Authority here in BC to do some additional primary data collection, specifically qualitative interviews, using a group of people with lived and living experience and elders who are going to help us to design a culturally specific interview guide, which we will be implementing for a subset of folks. And I just suggest that you contact Bernie for that one. I'll just throw that at Bernie if you have any questions about that. So Bohdan, I'll hand it to you to talk a bit.
Yeah, so a little bit more on the people with substance use disorder cohort. Again, we have data going back to January 1st, 1996. That's when a lot of these data sets came online and started collecting data systematically for the entire province. And the data sets that we've put together are PharmaNet, which is row-level medication dispensation data. So every time there's a pharmacist dispenses a prescription of, a medication prescription, that is one row in our data set. So you can imagine how many millions of rows we have for this cohort. It's well up over 40 million. It's a wealth of information. We have medical services plan data, which captures physician visits. So physician billing records are included there. The MSP registration file, the discharge abstract database, which is hospitalizations. Through the public health emergency, we've been fortunate enough to get access to provincial corrections data. We don't know how much of an impact that's going to have on this particular evaluation. It really depends what our population looks like, but it's useful information nonetheless, even if it's only historical information that we're drawing there. Perinatal services, the First Nation client file, I had a question in the Q&A about FNHA engagement and engagement of people with Indigenous background. Certainly, we've worked very closely with FNHA. We have access to the First Nations client file, but it's really only the FNHA statisticians who are able to access it. So again, our team has been working hand in glove with FNHA and their team. And if there is a sort of stratified analysis to do on this evaluation, it will be led by FNHA. And Amanda at the CDC has the same arrangement with respect to access to the First Nations client file. Frankly, I wouldn't have it any other way. I think that makes a lot of sense. Otherwise, we have vital statistics data, and new to this, specific to this evaluation, we're asking for coroner's data, which will give us specifically what substances caused the death in cases of overdose deaths. Housing and social assistance data will be new to us. We're expecting that in the fall, and we'll access the CDC's public health laboratory systems to confirm the COVID-19 infections. So our key outcomes here, again, are COVID-19 infection, drug overdose, both fatal and non-fatal, and continuity of medical care. And I always think of continuity of medical care as, forgive me if I'm using overly stats geeky terminology, that's kind of the stats geek. So I think of continuity of care as along the causal pathway to these sort of final outcomes like overdose deaths. So the idea is, if risk mitigation guidance can stabilize people enough that they can continue to receive their treatment for other conditions, that in turn may reduce the likelihood of overdose death and other adverse health outcomes, right? So I think it's important when we've had a lot of conversations internally and with our stakeholders about what are the appropriate outcomes to be evaluating in this trial. I think because it's so novel, I think we need to consider a range of outcomes, both social and health, and again, at different steps along the pathway towards some of these final outcomes that we really want to avoid. Of course, the program was designed to avoid COVID-19 infections, meant to promote social distancing, allow people to adhere to social distancing guidelines, and it's meant to give them an unadulterated supply of the medications that they need to, and in doing so, reduce the risk of overdose and overdose deaths. And so obviously these are outcomes that we need to include in our evaluation, but there's a lot more to consider here. So statistically, our approach is to conduct a propensity score match to construct a control cohort. So we'll be able to identify from our data sets who are the recipients of the risk mitigation guidelines prescriptions. Our challenge here, and it's a significant challenge, is finding a group of individuals who are similar in every way to those recipients of risk mitigation guidance prescriptions, but didn't receive the prescription, okay? So in doing this kind of statistical work, this kind of work, we're doing our best to replicate the conditions of an experiment, okay, an RCT. An RCT isn't feasible for this kind of program. It's not going to happen. Even if you did an RCT, it wouldn't reflect what is truly happening in the community. So yes, we're trying to get at a cause and effect kind of question. I don't use that term lightly, especially in cases like this where we're dealing with a brand new program. But our goal and our responsibility really is to give the most unbiased insight into the effects of this program on these outcomes as possible. And so that's our approach. Again, we're constructing a control cohort, and then we're going to use a technique called marginal structural modeling to assess the effect of risk mitigation guidance dispensations on these primary and secondary outcomes, okay? And the reason we need this sort of fancier statistical technique is that our exposure in this case changes over time. Some people will get a one-off prescription. Some people will stay on their treatment for weeks and months at a time. And the extent to which people stay on may change the risk of onward outcomes. And so we want to capture that. And you know, this kind of time varying exposure, it creates some challenges. It necessitates this sort of fancier approach. But this is something that I have to say, it's been used successfully in other pharmacoepi applications. It's by now quite an established method, and I've used it before and I've felt that it really works quite well. So I'm excited to see what happens. Of course, as much as possible, we'd like to kind of characterize our results specific to different types of individuals. So people who were receiving OAT at the start of their RMG prescriptions, people with diverse backgrounds. We'd like to make this as specific as we can. Of course, we're going to be constrained by the number of people, just the sheer volume of people that we have in our data set who receive risk mitigation guidance prescriptions. We'll do what we can. But that's the general approach. And I will say, admin data, you can do a lot with it. It's incredibly rich, but it's rich in a very narrow sort of perspective. So we have great information on people's medical history. We have service utilization. We have some final health outcomes, but we really don't capture, we're left to speculate about the implementation of the program, the perspectives of clients. So I was really excited. I was glad to partner with Karen and Bernie in particular on this evaluation, because I really felt like if this was strictly an admin data evaluation, we really wouldn't be capturing some of that really important nuance that, especially for something that's being tried for the first time. I really see these pieces of evidence as fitting together like a puzzle. One is going to inform the other just as much as the other way around. So I'm excited to do this in parallel with Karen and her team. Should we say anything more, or are we ready to go on to the next slide?
I think that's good. I mean, it's going to be interesting. We mean it to be a truly mixed method study, not a multiple method study. This is, the way that the administrative data analysis unfolds is going to, and what is found is absolutely going to affect the progress on our side and vice versa. And we've tried to create that structure in our project governance to allow that to happen and to make sure that we all know what each other are doing. Here's our incredibly ambitious timeline that always makes me a little bit nervous when I see it. These rapid research funding, these calls from CIHR were for a year of funding, and I'm going to pretend it's not September. And so we have a lot to do this year in our data collection and in our administrative data analyses. But through the support that we have from Ministry of Health and Health Data Branch that is helping us to get access to the data that we need, down to the communities that we're working with around the province, we are cautiously optimistic that we're actually going to be able to do this. I'll put it that way. So I think now we should go to the questions and the answers. I've seen the questions kind of popping up. So Amanda, should I just, there's questions that have been answered.
We can just give people a minute or two to put their questions in.
Perfect.
If they have any, yeah.
Let me fill this dead space by thanking again. I've thanked them continuously, profusely, folks at the Ministry of Health who have worked with our team and worked with Amanda's team to make these data linkages possible. A lot of work goes into this. And there are a lot of really dedicated people on the other end that are allowing us to do this. So thank you.
And if you are joining us from another province and you have some insights or some experiences to share with the way that this has rolled out in your province, please feel free to share those as well.
And I think if you put up your hand in the attendee list, I can allow you to talk if you'd prefer to ask a question over the yeah, by talking. What am I can't talk apparently. So yeah, so if you'd prefer to do that instead of typing something out, just put up your hand in and let me know, and I can unmute you and allow you to speak.
We have a space. I wonder if you know, our other collaborators who are attendees, listed as attendees. I see Bernie. Bernie, is there anything that you feel we missed and maybe you'd like to add? I know you always have a lot of great talking points to add to these presentations.
Oh, there we go. I think I just unmuted myself. Thanks, Bohdan.
Yeah.
I don't think I have much to add, but I think I just want to thank Karen and Bohdan for setting the stage for us, because this is has been a rapidly mounted evaluation, and you know, hearing your questions, I think, will really sort of help us continue to stay the course with an evaluation that's going to inform policy and practice.
We're all still on summer mode.
Either that, or we did such a great job that there are no
Questions.
no lingering questions.
Yeah.
I just wonder if there's anybody in the audience who knows about this program, has some personal experience they want to share. You know, where I'm always keen to learn more from people on the ground who have some experience with this, either as consumers or as prescribers. That's really important information for us.
So there's some questions in both the Q&A and the chat if you want to take a look there. We've got some popping up. Thanks, everyone.
A couple of questions in the chat. Thank you, Erica. Yeah, we didn't talk a lot about the participatory aspects of this project. So thanks for calling me out on that. I meant to speak more, and you know, it kind of just what comes out of my mouth at any given time is variable. So I will I'll extend a big thank you to Erica and to BC UConn Association of Drug War Survivors, because that is the reason why we are doing this project in effect. So Erica, we had conversations really early on, didn't we, where we talked about this guidance document and what it was going to mean for the community. We talked about the possibilities of research, as well as different aspects of the you know, an evaluation and advocacy as well, because the drug user organizations and groups and people with living experience are really driving the advocacy efforts and helping people to receive these prescriptions. So over the past couple of months, we've collaborated and we've come together to figure out what outcomes we wanted to look at, what the design might look like. And so certainly all of the data collection tools that we've created and the project structure has been shaped with input from the BC UConn Association of Drug War Survivors, as well as the PEEP team out of BC CDC. And I think that, you know, with this particular webinar, we did want to focus in on methodology, but as we think through how we want to go about reporting and thinking about the next phases of this evaluation, as well as the next phases of webinars and roundtables for the CoLab project, with in which the BC Association of Drug War Survivors is also involved, we do want to be mindful of honoring that participation and expertise that we get from people.
Right. I can take a stab at answering the questions from Edith and Deborah on the Q&A board. It's interesting you bring up PWM, Pandemic Withdrawal Management. It's sort of one of these interesting wrinkles in the implementation of this program. I hadn't heard that phrase used in reference to this program. I hadn't heard it at all. It had come up when we started reviewing when Amanda and her team really at the CDC started reviewing PharmaNet data and the indications that physicians gave for prescriptions, risk mitigations guidance prescriptions. So PWM was a common phrase that we saw, and I just find that interesting. I think that was, correct me if I'm wrong, Karen, but I think that's a terminology that physicians on Vancouver Island are using. Is that correct?
We're using PPRM, pandemic prescribing, for risk.
So that's another, I mean, that further illustrates the point. That's another phrase that's been assigned to this program. And it's interesting. I mean, this is why I bring up this aspect of implementation. Like, we really need to understand how we've gone from this single guidance document to what is actually being done in interactions with clients, right? So yes, this is one and the same. And yes, when if Edith, I don't know if you're a prescriber, it seems like you are with the use of that term. You are classifying your prescriptions as they are going to be captured. I'm glad to see that you feel they're helping patients. I wonder, I mean, it's really our goal, it's our responsibility to figure out how that's playing out over the entire province and within different patient groups with different backgrounds and different circumstances. So, but that's a good sign that, you know, at least you feel that it's making a difference. The other question from Deborah is, when will analysis data be available? That's going to be coming on an ongoing basis. We have an initial glance at some data, some of the admin data going up until the end of June. That's going to be ready in the next few weeks. We're being very cautious about that. It will not include a control group. We're not going to be trying to assign any sort of causality to what we're seeing. We're really just going to be describing the patient group, the group of clients who are receiving these prescriptions and some of their downstream outcomes. Karen and Bernie can speak to when they expect their original data collection to come out. It takes time. I know the final sort of admin data, we won't actually get that linkage until next spring. So I'm expecting towards the end, right? May 31st is sort of the end date for this grant. And I think it's possible that we'll have something for May next year. And just keep in mind that this is still changing here, right? Where we are seeing another spike in COVID-19 cases. There are a lot of people speculating, believe there's going to be a second peak. We're in the midst of this. This is, by no means are we out of the woods with this, and it's possible that the guidance itself may change. And so it's going to be important for us to stay connected, keep our ears to the ground, and make sure that if there are any changes like that, that they're incorporated in our designs and that we're able to capture those changes. And just to be clear, at least with the admin data collection, the last sort of date that we'll be able to capture data will be the end of December 2020. So, you know, March 2020 to December 2020, that's going to be our main study period. Okay. And one more question from Deborah. Karen, do you want to take that one?
Sure. So the cultural safety and cultural humility approach. Yes. So and from the Thunderbird, good to have you with us today, Deborah. Thank you for joining. Yeah, so we've had some really interesting meetings, not just with First Nations Health Authority and their data stewards, as well as scientists working in FNHA to talk about what this might look like and how we can support it and fund an Indigenous-led component of the primary data collection piece, but also to the Métis Nation of BC that we've met with to speak about how to capture some of the nuance around different Indigenous identities in the data as well, because clearly the First Nations Health Authority plays a very particular role in British Columbia with respect to geography and membership. And so there's just been I must say it's been a very welcoming experience to speak with the different stakeholder groups around what we're planning and how we can improve it. And that's a very, it's nice to see such interest in the research enterprise from groups, and to have their interest in sort of some of those methodological nuances that we're kind of struggling with right now. And yeah, so it's been fun. It's been fun, even though we're evaluating something that is not one uniform type of intervention. It's not looking like one thing that's been released out into the world. It's been taken up in very different ways across the province. That's part of the challenge.
But see, that's just as interesting as anything we produce on the final outcomes that we're reporting on, right? The implementation process, that's going to be every bit as important as the outcomes of this evaluation, right? Because these are things that we can potentially tweak, adjust, change as we proceed if this sort of program is something that we're considering to continue on into the future.
And one more question before we wrap up. How do we envision the knowledge sharing process with people who use drugs to participate, as well as with drug user groups? Very good. So we are in the process of hiring peer research assistants to assist with data collection, and so people with lived and living experience will be assisting with data collection as well as analysis and knowledge translation. So moving the findings out, and that will be shaped, I think, in large part by some aspects that we find, as well as you know, we have some sort of thoughts around how we can incorporate the knowledge sharing into the broader infrastructure that we have available to us through CoLab, for plain language summaries, for community events around BC where we can discuss what these findings mean for different communities given their context and their implementation. But all of that is still kind of up in the air. We've only had really preliminary discussions, other than sort of around the design and what the data collection tools are going to look like. We're really just getting started. And so if anybody has suggestions around knowledge exchange and what that can look like, by all means, please do get in touch with us, because that's all still to come. Yeah. Thanks for raising the stakes there, Deborah. Yes, we know that there are a lot of eyes on this project, and so that is why we're really committed to making sure it proceeds in a good way. Thank you. So I'm aware of the time. Brittany, can I ask you to make a comment?
Sure.
Thanks.
And I think it goes nicely with that last question about how people with either lived experience or not get access to this information. So we do have a web page and it's been shared before, but I just sent it to the chat. So if you want to be a part of our community of practice, which is a listserv and a place for people to come together to discuss things related to CoLab. So at this point, CoLab is a really new project and quite theoretical. So if you want to be more a part of the project and learn more about how health equity can be a part of the work we're doing around substance use, then I think it's like a great place to join. This is just one of the many projects that CoLab is working on, and the roundtable discussions and webinars are going to be created based on the interest of our membership. So the project is hoping to use the community of practice as a place to not only share the knowledge that's being collected from the projects, like this specific project, but to take the information that is being shared in the community of practices events like conference calls or webinars like this, the questions and answers that are coming up, and reapplying those to those projects. So you have a really interesting way of being a part of the project without necessarily being on the research team. So if you have a topic of something that's coming up in your community, whether you're a person with lived experience and experiencing something in your organization, or if you're a harm reduction worker and you're seeing something, please send us an email. My email's in the community. Once you become part of the community of practice, I have your email, so we can connect and start creating events where people can connect and talk and learn from each other. Because what we've kind of found from the beginning of this project is there's a lot of interest in supporting people with lived experience, starting organizations in their community, having activism around health equity and substance use, but there might not be a lot of communication. And so we're hoping this project will be a place for people to engage at all levels. So if you're interested, just click that link and become a member.
Thank you, Brittany. Okay, so I think that's all for today. Thank you so much for joining us, and I look forward to hearing from you.
Thanks.